Okay, so we have now another live case. I have coming from the Severance Hospital in Seoul, Korea. The first operator is Myung Ki Hong, and the second operator is Byung Kook Im. I think that the lab is ready, at least what I heard. So I'm sure that there will be a video of introduction. Good morning, it's still morning. This is Patrick Zereus. I have with me...
Yes.
And maybe you could present very quickly the panel, if we have time, during the procedure we will do that. I mean, yes. We want to go to action immediately.
Okay. Good morning, dear everybody. Professor Dr. Sarve is welcome to our hospital. Okay. Today we prepared the original classic imaging guided left main bifurcation cases. On the right side, my colleague Professor Kim, Byung Kim, and we have the interventionist, particularly in imaging, Jung-sun Kim. Okay, first of all, the patient case presentation, Dr. Kim, please.
Yes. Yeah, good morning, everyone. So let me introduce today's our case. A 75-year-old male was visited, the diagnosis of stiff angina. So on the angiogram, two vessel disease. And 10 years ago, he underwent PCI at RCA. His risk factor is hypertension and with CKD grade 3. On procedural studies on echocardiograms, there was no specific reasonable motion abnormality of a change. However, the ejection fraction was normal. But he had a chest discomfort and on the treadmill test, stage 2 positive. On laboratory findings, the creatinine level is a little bit increased. Others were not remarkable. Next. Yes, this is a CAG of these times. As everybody can see, on RCA angiograms, there was no specific tight stenosis, and also the prior stent was patent. The next one. On left angiograms, so as you can see, the mid-LAD tight region was noted, and also is mid-circumflex, just proximal bifurcation of the OM and proper stenosis was noted. Next one. Yeah, on spider view is some suggestion of plaque rupture haziness was noted on LAD ostium and L3X ostium, and also is some linear defect was can see in the proximal LAD region. Yeah, this is the angiogram of this patient.
In summary, actually, this patient is my patient. I fixed the right coronary artery almost 13 years ago, and then followed by me. And there is still a little bit the renal dysfunction, a little bit decreased the EGFR. So I'd like to have a little bit nervous of the use of the contrast dye. And on angiographic appearance, you see there is actually when you see that the size of the left main size is smaller than the circ or left main, it suggests angiographic appearance itself there is a very significant disease in the left main. Another strong evidence of the ischemia is a treadmill test only stage 2 positive. It means very significant and with the large burden of the myocardium. So to evaluate the coronary status, we do the IVUS from the LAD and CIRC. Okay, Dr. Kim, please.
So did you do some kind of simple Finet calculation, taking the circumflex diameter, the diameter of the LED, and conclude really that this main stem is clearly more than 50%? And I think that there is a lot of calcium in the roof of the main stem, yeah?
I think so. I agree. Okay. Dr. Kim, please.
Yeah.
What's the size of the guiding catheter?
Pardon?
Guiding catheter.
Guiding catheter.
What is the size?
It's a 7 French
Yes.
XB. Go ahead.
So let me show the IVUS image. This is a pullback from the LAD. There is a two tandem region, mid LAD and left main, distal left main. So this is a distal LAD site. Vessel size was 3.0 and minimal lumen area is 2.69 and lesion length 14 millimeter here. And the pullback from to the proximal part, there is a fibrotic plaque and some calcification here around 9 o'clock. And approaching to the left main, there is some plaque rupture, and
This is a distal left main.
this is a distal left main. Distal left main, proximal LAD vessel size 3.5, and left main vessel size more than 4.0, 4.5. And region length is 22 millimeter at the proximal part, and minimal lumen diameter of the left main area of the left main 3.1.
Okay, then, and the CIRC?
Here is a pullback from the circumflex. Distal also have another region at the circumflex
처음 이미지 보여주세요.
distal part here. And here is a circumflex proper, and then there is a significant lesion at the distal part. Minimal lumen area 0.26, and approaching to the left main. Here there is a fibrotic plaque here, and quite large vessel. There is a calcified nodule. Here is a left main, and left main also minimal lumen area 2.78. Lesion length was around 18 millimeter.
Okay,
And-
based on the IVUS and the angiography appearance, could you show us the first angiogram, first shot of it? You see, this is the angiogram taken today, and you see there is a very small size of the left main, and some narrowing in the mid portion of the circle. Next view. This is the spider view with some severe angulation, but the circle, the ostium of circle is severely narrowed, and there is some suspicious plaque rupture between the LAD and the ostial circle, and some hazy, linear haziness of the LAD ostium, and the more distal portion, mid-LAD is significantly narrowed. Next. This is the areocranial view. And actually, the IVUS finding is that the mid-LAD portion was significantly narrowed. I fixed it already. Next. Wiring and the IVUS evaluation. Next. 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 This is a 2.5 Janus Korean balloon, Korean-made balloon. Next. Okay, this is a 3.0, the Zion's stent, and fix it, the dead lesion up to 14 atmosphere. Next. 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 No. 전. 안 찍었어?
아니요. Frame.
Okay, this is the final angio after the mid-LAD portion, and to save I'd like to concentrate the left main bifurcation. Then, okay, next. And then evaluate the circ. Then, And based on the IVUS finding, small, the lumen area in the mid portion of the circ, and the predilation with 2.5. Next. Okay, next. Okay, this is the current stage. My plan is the two-stent technique from the mid portion of the stent, the circ, and extend to the ostium of the circ, and then stent in the LAD and into the left main. Is a two-stent technique, particularly with the crushing stent technique. That is my plan. Any other comment or the question about this case?
Just to be the devil's advocate, I mean, we have seen the ostium of the circ is certainly not entirely normal, but angiographically is not so unpleasant. So the question is there somebody in the panel who would say a stent overlapping the ostium of the circ and then a pot and then eventually an IVUS to support that attitude? I saw a hand raising, and that's Yves Louvard. Yves, could you defend that position?
I have the same impression about the proximal circ, and I don't think the IVUS shows a very tight lesion. Second, if there is a real lesion there, it's short and very close to the left main, so can be improved by the by the left main stenting itself, what we call stenting two vessels with one stent. So another option will be to stent the lesions that have been pre-dilated, but not close to the ostium, leaving some space there. Then to do a crossover stenting, using the diameter of LAD, going back to the ostium of the left main, because this is diffuse disease, and do a pot. And after that, do a kiss, and judge the result if it's necessary to put another stent at the ostium. Or another option is to begin by the left main and to stent at the end, after the kissing, either the whole proximal part of the circ or the only part affected by the lesion. So crossover stent to LED for me.
Maybe the only extra argument, Yves, is the fact that on IVUS there were suspicion of some disruption of the carina. It was not very clear. So certainly with OCT you could clarify that. That might be an argument to be for two stents instead of one, but I'm not so sure about that.
Particularly, there seems to be ulceration there, so there can be a plaque shift.
Yeah, I think whatever two-stent strategy that we're going to use here, probably have to cover the ostium of the circumflex well, to basically make sure that the entire carina is protected and covered by the stent.
Totally agree. I think this is a two-stent case. You've got both vessels are severely diseased. There's a lot of calcium. It's going to be complex, and there's ulceration and an ulcerated plaque right at the carina. So to me, this is a two-stent case.
I think we would expect a lot of carina shift after the stent implantation. So I am in favor of two-stent technique, either a double kissing crush or pull out at the discretion of the operator.
Would anybody like any functional assessment of those lesions with an IFR, just to see which is the most significant, or if there's any which is not significant?
Well, it's hard when you have a left main that is diseased, so it's going to be significant from...
In the patient with kidney function, which is not optimal, not to say suboptimal, I'm being impressed recently by the people using the dynamic route mapping of volcano to do a lot of procedure without injecting contrast. It seems to be, when you get used to it, I mean, certainly you can place a lot of stent without making injection. Any comment from the panel? I see somebody who agree with that. Any comment?
I think the way we can use the IFR to see at different levels which is the most significant situation, also to predict the new method they have, the volcano method they have, might be quite helpful.
자, 본론 하나 줘.
네.
본론 줘.
본론? 얼마짜리?
2.5.
2.5 아까 쓰던 거 주세요.
Dr. Hong, could you explain your strategy of two-stent technique now?
I'm trying to crushing stent technique. I'm so happy to hear the voice from Professor Sung in this conference.
So is this a DK crush or is this a classic crush?
Mini crush. Mini crush. Because this case is by the image guided, so I did try to fix it all of it the image guided. So I know that there is several scenario about it. I think it's a very good chance what happened in the future appearance will be validated by the IVUS. So I'd like to. Okay. 본론을 다른 거 주셔야겠어. Okay. I do like to validate all things by the IVUS finding. This is the stent was a synergy stent. 3/5/20.
Yeah, that's 20.
Okay, test. Okay, go.
10, 11.
이걸로.
One more. 11, 12,
16.
16.
이걸로. Okay, anyhow. Inflate.
Inflate. 이거 잡아. 이거 잡아.
16.
16. 16.
18.
18.
20.
20.
이걸로.
Deflate.
Okay, take an angiogram, and then I will deploy another synergy stent from the distal left, proximal LAD to the left main.
Just one question. Are you going to overlap with the mid-LAD stent, or are you going to just put...
No. If there is some normal segment of the coronary artery, just let it alone. I'm not intentionally not do the overlap.
I know we're trying to save on contrast material, but after putting the stent and the circumflex in before pulling the wire out, wouldn't you even like a little flush just to make sure there's no distal dissection, no nori flow, or do we have to wait for chest pain?
이게 서클이고요. LA.
Okay.
I know Dr. Hong doesn't like frequent contrast injection. He wants to
다시 준비해. 와요 다시.
only IVUS.
Yes, one of
Yes,
the main
but he
focuses
removes the wire of the circumflex without knowing if there is a dissection distally, if some souvenir.
Okay, and yeah,
and
I
it
will
was
take an
difficult to
angiogram.
recross.
Ready?
And another point about overlap, the technique you use, there is overlap of metal in the bifurcation, and this is precisely at the level of the carena. And this metal, maybe 2 layers, with will maybe never endothelialize because this is submitted to high velocity. And this is, my opinion, precisely the place where we need only 1 layer.
Okay, ready 주세요. Okay, hopefully, I think the ostium circ is still acceptable, and stent deployment is still acceptable. So I will do the more procedure, going to the stent deployment from the proximal LED to the left main. Okay, 3-5.
3-5.
시너지.
시너지 스탠.
좀 길게 주지. 28죠. 오케이.
28.
28. After the stent deployment, I'd like to try cannulate and circ.
Well, I don't use DK crush a lot, but I thought whenever you attempt a crush technique, actually it just makes sense to do a first kissing first. You know, actually it helps to improve your access to the side branch. You know, probably 100% of the time you're going to be able to get into side branch. When you have a classic crush, there's this very small chance that you have difficulty wiring the wire sometimes into the side branch.
Actually, the DK crush is developed in the first generation, but nowadays the stent profile itself is very, very excellent. So in the current generation of stent, maybe I think is any kind of the two-stent technique is the equivalent. It depends on the anatomy. So therefore, I'm not insist the DK crush. So let's see. I will try to the cannulate.
Maybe I missed the point, but did you use the IVUS to make the measurement of the length of the stent that you have implanted? Because distally is almost perfectly in overlap with the stent implant in the LED, and I guess at the level of the main stem is also pretty good. Now there will be a small gap there between. No, I'm not so sure about that. But did you
Yes.
use the IVUS to select your stent, or is it just by pure practice?
Of course, of course.
Yeah.
됐어. 자, 한번 장 찍자.
Yeah. Okay, I'm ready.
가자.
Pretty nice, eh?
Okay.
In terms of length.
Hold on. 11, 12, 14,
16.
16.
This is a 16. 3-5. The okay.
Wire watch.
Give me a first wire.
Yeah.
Is this the angle
Before
that
that, the text in it.
Do you plan to perform a pot now?
First of all, I'd like to cannulate first, and then do IVUS, and then I will decide to a pot or not.
Because I presume that at least in some part of the left main, this stent is not well opposed. So if you put your second wire now, there is a risk of crossing outside.
Yeah.
And this is not phantasm. I have seen that several times on CT scan at 6 months, for example. Sometimes it's a surprise.
And Dr. Hong, the LED
Yeah,
wire
you're right.
is located at the seams occurred. So could you see the distal part of the LED wire? Can you show us?
Okay, okay. Thank you. Thank you for the correction.
Yeah, actually doing a port will help to facilitate the wire into the side branch. My question here is, do we cover the ostium of the left main?
Let's check with the IVUS. I'm not sure it is almost be covered or not. I'm not sure.
And the port has also another function. What we have now, I know that this is not the end of the procedure, but you have a bifurcation which is really curious because there is only one single diameter, 3.5, for the 3 segments. And this is very far from what we can call a functional anatomy of a bifurcation.
You are right. But okay, let's try.
로드맵? 로드맵?
아니야.
더 앞쪽, 더 앞쪽.
Try to cannulate another pilot 하나 줄까요?
파일럿 하나 더 주세요. 오케이.
This is not good. The wiring was done in the proximal part, but I'd like to cannulation in the more distal test. That's true. Okay. Okay, good.
Dr. Hong, what's the reason to cannulate distal part of the circles? What's the reason?
When I cannulate the wire in the side branch in the proximally, after the kissing stent, then there was on IVUS finding, the stent looks like a kissing stent. There are a lot of the stent strut was in the bifurcation lesion. So imaging guided the stent technique. The optimal stent was first of all the absence of the stent strut over the side branch ostium, and second one is stent was fully opposed to the vessel wall, and finally try to the larger lumen area. 1.5 볼륨 하나죠. Lumen area ostium of the circ.
트랙 불러줘요.
So I will try to dilate in the ostium of the circ and the kissing balloon, and then what is the current status, which will be validate the IVUS.
I think for crush technique, I think the classic teaching is to wire more proximally, because this will avoid going underneath the stent struts so that when you do a kissing, the ostium will be missed by the stent. I think that's what we were taught, to cross more proximally rather than more distally.
Okay, let's check it. Give me a little time.
Yeah, obviously, sometimes you can't choose. Yeah, if you can get it through, it'll be quite good already.
Easily pass. Okay, inflate.
Inflate. 14. 18.
이걸로.
Deflate.
자, 3-5. Non-compliance.
Personally, when I'm kissing in a double stented bifurcation, I use semi-compliant balloons because there is no risk of dissection, and you can adapt the pressure to the diameter using the pressure.
Okay, this is a 3-5 non-compliance balloon.
서커가 조금 깊습니다.
Okay. Up to, go.
18.
20.
20.
The balloon. Give me another 3-5 non-compliance balloon.
At the last ABC course, Eve, we had this wonderful presentation about even a non-compliant balloon has to be inflated quite slowly for a long time to achieve all the radial force that you needed. And even the second inflation is different from the first one, so it's not really non-compliant. But I was impressed by the difference in diameter between the quick and the long inflation.
Was really incredible.
아니,
So
이거 먼저 해. 올려.
we added to the long inflation that was suggested by our Japanese colleague already a few years ago. We added the fact that a stent is very easy to deploy. Even at 5 atmospheres, you can deploy a stent. But was shown by Dr. Finney was that you cannot reach the nominal diameter before the third inflation.
12.
So it's recommended to do 3 inflation to have a full balloon inflation.
Why?
Long inflation and 3 inflations.
Okay.
It's not published, so I cannot show. You cannot find this data, except it on bfurc.net website. You will find it by Dr. Finney.
You are right. Okay. Let's check it. What's happened?
풀지 마.
Let's prepare the IVUS. First of all, sir. And the point is what is the lumen section, lumen cross-sectional area of the ostium of CIRC. Second one is the stent shot status at the distal left main, really fully opposed or not. Finally, stent was covered or not in the left main ostium. Okay.
Can I just ask Dr. Labat, do you think final kissing with high pressure is equivalent to a port?
For me, they are complementary. They don't do the same things. What is doing a kiss, if you use the 2 distal diameters, the 2 normal distal diameters, is putting the carena in the good position to support the myocardium supported by the 2 branches, proportionally to the diameter.
Okay,
And
Dr. Kim, please.
the pot is mainly at the end.
Show the
There is a
IVUS
feedback
image
from
on the
the
screening.
circumflex.
At the end is to correct the oval distortion created by the kissing.
Here is
Go
stent.
ahead.
There is on the thigh
Yeah.
section, well expanded stent, more than 3.30. Symmetrically well expanded stent. And approaching to the left main. Here
Now
is a
coming
left main.
the ostium of the CIRC.
It's well opened circumflex ostium. And here is a left main.
Okay.
Yeah.
Okay,
Almost
please
covered. Yeah.
measure the ostium of the
ostium,
CIRC
circumflex. Yeah.
and the estimate that the stent strut was fully opposed to the vessel wall.
Yeah.
Please tell the audience.
Yeah, let me
about
measure
that.
the circumflex ostium minimal lumen area. Usually recommend more than 5.
What is the larger diameter of the main stem and the smallest? Because it looks quite elliptical.
Yeah.
This is what is observed in bench, in soft bench when we use kissing balloon to finish the case. That's the reason why I'm normally in big vessel like left main. I'm always finish with a pot to have the round shape.
Okay. Please show the IVUS.
Yeah.
LAD.
Okay. What is that?
What is that portion?
Oh, okay. Go ahead.
Circumflex ostium.
LAD first.
Yeah, let me check. Yeah, pull back from the
Pull back.
LAD. This LAD. And there is some plaque burden at the distal elite, and here is a distal edge of stent, distal stent. There is no dissection, well expanded, around 3.0. And maybe here is a minimal stent area portion. We will check again later. And here is a proximal part of stent. Yeah, there is some bare portion, and then very short portion of the bare stent portion. And here is a distal part of proximal stent, and there is no dissection. And this stent is somewhat asymmetric expansion, and there is some circumflex. Circumflex ostium is quite well open. Yeah, it's somewhat asymmetric expansion of stent at the left main. And here.
Okay, let's take it once again.
Yeah.
With the stent strut was covered by the
Left main,
left main.
main ostium or not. I will advance it and the pullback of the guider. Okay.
Right, please.
Right, please. Yeah.
Another IVC examination.
Right. No. Right.
And record.
You do that. Yes, okay.
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 Yeah, here is a pullback from the left main, and ostium stent here. Yeah, stent is somewhat protruded.
The ostium of the left main was covered by the
left main
stent.
ostium. Yeah.
And Dr. Serway's comment that there is some eccentricity, asymmetricity of the stent expansion left main. The asymmetry is one of the index to predict the future adverse event in the BRS. But as we know, in data from the drug-eluting stent, asymmetricity is not important. Just a simple and strong predictor is the lumen cross-sectional area. So based on the IVUS finding, when you see that bifurcation area, only one cut of the stent strut was the position in the bifurcation area. So it's almost to be optimal.
Okay. Dr. Hong?
Yes.
Time is limited, so congratulations for your excellent demonstration. Thank you.
Okay, thank you.
Can we see the angiogram?
So I would like to introduce the next presenter, Dago Bak from Assam Medical Center. His title is Metallic DS All Equivalent. Dr. Bak, please.
Okay, thank you, Dr. Sung. So I'm going to talking about the metallic drug-eluting stent, the all equivalent insight from random trial, meta-analysis, and registry. Looking at the second generation drug-eluting stent, we are the available diverse type of drug-eluting stent, durable polymer coated and the biodegradable polymer-free drug-eluting stent. Also, the next version of the bioabsorbable plan, there's usually physicians select on their preference and on the basis of clinical and lesion characteristics. So, and looking at this review article, and is there any difference in outcome among contemporary drug-eluting stent? And looking at the diverse, the stent-specific individual random trial, there are many random trials conducted to evaluate, to find a difference of contemporary drug-eluting stent. Overall, was no difference in primary endpoint. So, and looking at updated meta-analysis, Tullio-Palmineri was published JAG 2 years ago. They evaluated 51 random trial. It's 52,000 patients who was enrolled. They do network meta-analysis. Looking at the efficacy, the outcome is compared to bare metal stent. Taxus Cypher stent is a first generation, second generation contemporary was better than the prior stent. And the safety issue, and compared to bare metal, the Taxus Cypher and the current contemporary drug-eluting stent was much better. So, and this is also translated to some reduction of death and reduction of myocardial infarction. So, are there any major difference in clinical outcome between most widely used contemporary metallic stent and the difference in RCT and the registry? So to evaluate the CER comparative effectiveness research, we do several stent-specific prospective the registry. This is IRIS-DS registry. we evaluated the 7 registry. The 17,000 patient was compared, the median 3.3 year follow. Looking at the Kaplan-Meier curve of primary endpoint, target vessel failure, overall there was no significant statistical difference. And the patient-oriented outcome, MACE, including all-cause deaths, NEMI, any revascularization, there was no difference. And the adjusted with the Twang method is a multiple group propensity score analysis. Most commonly used the giant stent. Overall stent was similar, but compared to the Resolute, giant looks better. And the MACE was there is no statistical difference overall. And looking at the deaths was compared to first generation Cypher, contemporary slightly better. There is some point, there is some statistical significance. TBR was no difference. And then definite probable stent thrombosis was favored for contemporary drug-eluting stent, but the statistical not significance going to limited number of stent. So looking at the real-world data, different contemporary drug-eluting stent, there was no remarkable between stent difference with respect clinical relevant efficacy and safety outcome. You can choose any contemporary drug-eluting stent on the basis of a clinical and lesion subset and combined with physician preference. And what about the complex region? Is contemporary drug-eluting stent for complex patient or region characteristics is diabetic and lemon disease. Looking at the diabetics, there are many reports shows differential response in diabetic patient after first and second generation drug-eluting stent. To evaluate to define any diabetic impact, and we divided diabetic and non-diabetic in each stent-specific registry. They're looking at the target vessel failure, cardiovascular death, target vessel MITVR. This is non-diabetic patient. This is diabetic patient. Overall, there was no statistical difference in each comparison of the contemporary drug-eluting stent. So the patient-oriented outcome MACE in diabetic section and non-diabetic section, the non-diabetic diabetic section, we did not find any difference between stent group comparison. This is target vessel failure compared to the giants. We did not find any difference in non-diabetics group. Also, we did not find any difference in diabetic group. This is the same major adverse cardiac outcome is compared to giant stent. We did not find any difference in non-diabetic group. This is the diabetic group. So, and there is a fair-wise comparison contemporary drug stratified diabetics, suggest the 3-year rate of target vessel failure and MACE was similar among different type of contemporary DES. So we did not therefore identify any differential impact diabetics on the relative clinical outcome of several type of contemporary drug-eluting stent. What about lemon diseases? As shown in the live case demonstration, lemon disease is definitely ultimate target of the PCI. So, and this is published in the JAG a couple of weeks ago, and evaluated the second generation contemporary drug-eluting stent for the lemon disease. We evaluated 4,400 patients, full 3 prospective registry, and this is the flow diagram, and 2,600 patients evaluated, nearly more than 1,000 giants, 232 is bioluminescent eluting stent, 600 the promo stent is the 600 Resolute stent. So we do some multiple treatment propensity analysis. Looking at the result, this is observed outcome Kaplan-Meier curve. Overall, there was no difference between stent group, and after 1 year, after exclusion of the periprocedural MI, there was no statistical difference at all. So major adverse cardiovascular event is patient clinical outcome. There is no difference between group, and also landmark analysis shows the similar outcome. And this is the adjusted hazard ratio using Twang method as a reference of giant stent. We did not find any difference by bioluminescent eluting stent comparison, the Promos and the Resolute. This is consistent for major cardiovascular event. There is no difference between the stent comparison, and in this full analysis, 3 prospective registry involving unrestricted use contemporary drug-eluting stent for distal lemon disease. We did not find any significant between stent group difference. We can choose any contemporary drug-eluting stent for lemon stenting on the basis of a clinical and lesion subset, also a sharp distal bifurcation, 1 or 2 stent, and combined with a physician preference. So, The drug-eluting stent 2018, we now have reached a mature milestone in PCI with the contemporary drug-eluting stent. Why do we need a better drug-eluting stent? To further reduce the restenosis and early and late stent thrombosis. Second, to improve lifelong integrity and patency of drug-eluting stent, like a stent fracture, some stent deformation. And to reduce long-term dependency on dual antiplatelet therapy. This is another important issue to improve the stent knowledge. When technology stops continued innovation, I think the knowledge will also stop. Thank you for your attention.
Dr. Bak, thank you for your nice presentation. So it's an honor for me to introduce the next speaker, Patrick Schrijf from Netherlands. He will talk about the future of coronary imaging and the coronary physiology. Professor Schrijf.
Thank you very much, Mr. Chairman. This is a lecture that I do generally in 40 minutes, so I'll try to do in 10 minutes this time. When I left the university, we were using the equation of Young to measure the gradient. And thanks to Lance Gould, he simplified that equation by using the friction and the separation and the velocity. Kirkcaldy made the things quite attractive. And in 1988, I had access to the velocity wire, and then 3 years later to the access to the pressure wire. And for a few years, I combined the pressure wire and the velocity wire in an attempt to understand the physiology. What you see here is the velocity, and then in transplantation, we were stopping the heart with adenosine. You see the velocity dropping as well as the pressure, and then we were pacing the patient. We had also the left ventricular pressure and the DPDT. And you see here the pressure velocity curve and the moment where we stopped the heart and we could get in one beat the pressure velocity relationship during maximal hyperemia. This is what you see here. Mind that the date of this work in human was June 17, 92. So after that, we had in the lab already at that time in 93, I published that in 93, PA, PD, the average peak velocity, and in the lab we had the instantaneous gradient. So you could see here the left ventricular pressure, the DPDT, the velocity. We had something which was already the instantaneous pressure gradient. And then using the hyperemia, we could calculate this index of hyperemic diastolic velocity pressure slope as well as the pressure at zero velocity. That was in 93, but, and we create a few parameters. But the mistake that I made is that I did not realize the beauty of this development. And as you could see today, we are still using this combination of FFR and CFR, and you can basically describe 5 regions, the region adequate and concordant above 2 and above 0.8. Here the reduced and concordant below 0.8 and below 2. Here typically a focal lesion more than diffuse, that region more diffuse than focal, and then the real situation of the small vessel. Now, let me see, I think I oh no. Then later on, we keep working with this technology of pressure velocity loop. We are now a quarter, 18 years later, and we're still comparing science and velocity, and we still have these parameters of FFR, coronary flow reserve, hyperemic resistance, micro resistance, epicardial conductance, microcirculatory conductance, and today, individuals like Justin Davis and Gabriel Scanet are even looking at forward compressive wave and backward compressive wave. And this is a cartoon illustrated from their paper showing that you could assess these parameters on top of what has been developed over the last 15 years. And recently, comparing DES and BVS, the only thing that we could demonstrate as a difference between the two technology is the fact that these forward and backward wave are somewhat different in the BVS because the BVS is undoubtedly more compliant than the metallic stent. So if you look, what happens is that between the FFR developed by Nico Peltz and Bernard de Bruyn, we had the CFR era in '97 with Debate 1, 2, Destiny, and Frost. We convinced the world that stent was the way to go and the balloon was not the way to go. And as you could see, it takes 7 years for Nico Peltz and Bernard de Bruyn to develop DEFER, and another 8 years to do FAME 1, FAME 2, and FAME 3. And then suddenly there was the disruptive technology of IFR introduced by Justin Davis with Advice 2, Syntax 2, and then Define Flare and Sweetheart. The good step, it takes only 6 years to go to an outcome trial, and today the people are convinced in more than 5,000 patients that the IFR is equal to the FFR. Now, on the other hand, in '97, together with the people of Stanford and an engineer called Kees Lager, we developed the Angus, which was the fusion of the angiography and the IVUS. And from there, we start to develop shear stress, which was almost an exotic type of research at that time. But nevertheless, today we use non-Newtonian pulsatile shear stress to assess the different quality of bioresorbable scaffold, and it is very useful. You could find in the European Heart Journal a comparison of these shear stress pulsatile in different bioresorbable scaffold. Now, what is interesting is that suddenly from Stanford, Charlie Taylor developed the FFR-CT and color-coded the FFR-CT, and there was a family of trial, Discover, Flow, De facto, NXT trial, platform, and syntax, and we have the same planner. And then another development, quite unexpected, is that suddenly the people of the conventional angiography say to themselves, we can also do a 3D angiography and then start the generation of 3D angiography with CFD, computational fluid dynamic. I must say that, and I want to warn you, that there is a simple way to do, which is the Lens-Gould equation, and there is a difficult one, which is the technique of the Navier-Stokes. So today, where are we? I mean, there are at least 3 techniques of QFR. This is the 2 academic that we developed in 2014, but in the meantime, they are commercial. And recently, we did a Bayesian meta-analysis to look what we could find in the literature, and it is amazing to see that there are a great number of studies, and the sensitivity of the QFR derived from the coronary angiography versus the FFR of IFR derived from the pressure wire is quite impressive. A sensitivity of 89%, a specificity of 90%, and also the other parameters. And what you see here is basically the shoulders of the area under the curve, and we are publishing in the European Heart Journal, It doesn't matter if you use the Lenz-Gould equation of the Navier-Stokes, you get the same type of accuracy in terms of C statistic. It doesn't matter if you use FFR, Angio, QFR, or other software, you get also very accurate. And finally, the type of analysis offline of online is identical. So there is no difference in diagnostic performance between the type of method of pressure drop computation, software, online, offline. So I predict that since more than a quarter of century, we have the technology pressure and velocity-wide to analyze in great detail the coronary physiology, epicardial conductance, microvasculature resistance. However, we have no specific treatment for the microcirculation disease, and the use of the current single pressure velocity-Y is cumbersome, time-consuming, and costly, and will probably remain a research tool. What I predict is that the color-coded angiography, if I can call it, with QFR, virtual FFR, and FFR angio, will be embraced by busy operator who wants to have at low cost and swiftly the physiological justification of their treatment of the epicardial vessel. When conventional fluoroscopy angiography will be replaced by CT angiography, FFR-CT might become a surrogate of the angio and pressure-derived FFR. Quickly, I would say what I see coming in the imaging. First, we see fusion of methodology of OCT, grayscale, IVUS, and angiography. This is a typical example of an absorb with the fusion of OCT and angiography, but we have done the same in 4D for the wall stress. You will get very soon this technique in the lab. Don't forget that in 2025, the computer will have the intelligence of the brain, so we will be able to do that. There are at least six companies which has developed IVUS with 60 megahertz. The pictures are really gorgeous. In terms of OCT, what we see is the emergence of ultra-high speed OCT. This is a conventional OCT at 100 rotations per second. We have developed in Rotterdam 5,000, but this is the technology which has been developed in Korea by an academic group in Korea with 500 rotations per second. The big advantage of that is that the 3D reconstruction is of higher quality and a lot of artifacts are disappearing. Another novelty is the hybrid catheter. You see here the IVUS, and on the right-hand side, the OCT. That's making great progress, and I can guarantee that it will be soon in the lab. And from there, you could do a 3D view with tissue characterization. You see here in yellow the lipid, the calcium in white, in green the macrophage, the stent in blue, and the guide wire in gray. This is a technique, the photoacoustic imaging, the merging of sound and light, specific to Rotterdam. We use a laser beam to hit the plaque, and then we go an acoustic effect. And I don't have to describe that in detail, but it is really the Rolls Royce of the tissue characterization. You can really, at any depth, identify many components of the tissue, but our first pullback technique is just made working. Near infrared, the IVUS has improved the quality. We have now an extra software for collagen detection so that you could see the vulnerable plaque without thick cap. There has been a lot of progress in intravascular molecular imaging of plaque biology. This is a marker for early stage of atherosclerosis. You can use indocyanine green. You can detect fibrin, you can detect oxidized LDL, you can detect macrophage. I'll just show one example of an OCT pullback, which has been labeled the day before the sacrifice with the compound, the atherosclerotic, and the VPM thing, so you could detect the cathepsin in this early stage of the disease. Finally, one word about the near-infrared spectroscopy. There are a software for collagen detection. I show you that. But now you have the near-infrared autofluorescence. We don't know exactly what it means, but certainly after the indocyanine green, and also spontaneously, we are trying to understand what are the signal which is autofluorescence. And then the top of the top is what we call the time-resolved fluorescence spectroscopy, fluorescence lifetime imaging, FLIM, like they call him. Just in a word, it's a technique which relies on the assessment of the fluorescence emission decay, decay time, in nanosecond of molecule being excited with pulse light. So the elastin will respond with 4.5 nanoseconds, the collagen type 1 by 6 nanoseconds, the lipids, certain lipid, the LDL by 2 nanoseconds, and the cholesterol linoleic by 13 nanoseconds. And at the HA, the first image in the pullback with the OCT was present in atherosclerotic plaque. So you realize that these rainbow that you see here correspond to all these molecules. And as you could see, the barcode, the color barcode is expressed now in nanosecond because the light has, the OCT has the speed of the light. So the question that I have in conclusion is that from a practical point of view for you, hybrid dual probe catheter allow the evaluation of the plaque microfeatures such as cholesterol crystal, detect by OCT, inflammation, macrophage, neovessel that were unseen by standalone IVUS. Established marker of plaque vulnerability such as plaque burden and lipid component are detected at the same time. The issue is what we are going to do with all these devices because the entire coronary system is 35 centimeters long, and when you get all this information, it is quite disturbing and disruptive. But practically within 5 years, most of the hybrid imaging technique now in preclinical phase will be utilized in the clinical arena. That's something for you. Software for online blood simulations is likely to be developed that will enable the shear stress and wall stress calculation online. I have shown you this shear stress, but very soon it will be available online. And like the color code angiography, you will have your angiography expressed in shear stress and wall stress, but we will have to learn what it means, and it could take a long time. So future studies of intravascular imaging devices are expected to shed light into the mechanism of atherosclerosis evolution and precise risk stratification of vulnerable plaque. The future is bright.
Thank you. Thank you for your excellent and comprehensive presentation regarding future coronary imaging. 5 minutes left for panel discussions. So any question and comments from panel? Please. Yes.
To Dr. Severance, the shear stress to me seems to be a useful tool for a SFA disease assessment.
Definitely, I mean...
more than coronary.
Sure. We make the difference between what we call the macro shear stress at the level of the vessel, and you're right, in periphery it might be very interesting, in the aorta very interesting, but what we do also is the micro. And for instance, on the absorb, we have described clearly the recirculation that you have behind the struts, and we try by all means reducing the thickness of the struts, embedding better the struts to eliminate this element of recirculation behind the struts. So it has a clinical application, and in the European Heart Journal, we have published different type of stents showing that it has an impact.
Another quick question for Patrick on the whole. This is incredible, the amount of information that we're going to gain from the molecular level up with the type of imaging technology you're talking about. So is this going to launch a new era, Prospect 3, Prospect 4? What do you see as the future of collecting enough of this data and using big data in large population studies from invasive angiography with careful wall shear stress and molecular imaging, as you talked about, and trying to connect that to clinical outcomes? That's always been the big missing connection, and maybe we just haven't had enough information. Prospect wasn't enough, and NIRS IVUS may help, in Prospect 2, but there's so much information.
I have no response, and I have a lot of response. Why I'm saying that? Because since 15 years, we have this meeting called Vulnerable Plaque, where you have really the top of the top, which is coming to talk. And it's very difficult. We have been in all kind of direction. I mean, from the genomic of the kids, where you can detect a disease in a very early stage, to a multi-slice CT scan at the level of population, healthy individual, to high characterization of the coronary artery like I have shown. At some point, you have to put that together. Clearly, from a medical point of view, what has been very important for me is the fact that we have entered a phase of the preventive primary PCI. You have a problem, the patient is on the table, now it is the question, it is the moment to see what kind of lesion should be treated. And of course, it's complex because it is mechanical, it is compositional, and it is enzymatic, and it is shear stress, and it is wall stress. So to predict that lesion is going to rupture tomorrow remain extremely difficult. But the fact that we are in this phase of preventive PCI is already something very good.
Yeah. Right.
Okay. So no further questions. So okay, I would like to close this session. So thank you again, all contributor. Thank you.